Welcome to ASHA's Sex Plus Health podcast. I'm Martha Kempner. January is Cervical Health Awareness Month. The American Cancer Society recently released new guidelines for cervical cancer screening that include HPV testing with self-collected samples. We invited Dr. Rebecca Perkins from Tufts University Medical School to talk about what's different in these new guidelines and how self-collection can help get more women screened. Dr. Perkins, thank you so much for being here. So can we start with you just introducing yourself and telling us what work you've done in HPV? And also, can you explain the Enduring Guidelines Committee to us?
Sure. So my name is Rebecca Perkins. I'm a professor of obstetrics and gynecology at Tufts Medical Center. I've been working in HPV for a couple of decades now. It is a wonderful place to do research because there's so much happening in prevention of cervical cancer and other HPV-related cancers. I've been working with ASCCP for many years, as well as the American College of OBGYN and the American Cancer Society. Between 2017 and 2019, a national consensus of 19 organizations got together to make new updated guidelines for the management of abnormal PAP and HPV tests. Many people know these as the ASCCP guidelines, and ASCCP is certainly the biggest promoter of these guidelines, but it was actually a national consensus of 19 organizations that created these guidelines that make a framework for how to manage abnormal results. It's managed by risk, not exactly by test results. So if someone has a risk of 1 in 1,000 of developing precancer over the next 5 years, then we say you are safe to come back in 5 years. On the other hand, if their risk is more than 4 in 100, we say you need to come in right now and get a biopsy to see what's going on. So then when you have new tests coming out, you can apply those tests to the risk framework. And so if a certain test result will, let's say someone is positive on the dual stain test, which is sort of an upgrade to the regular PAP test, then the risk is 9% of having precancer. So we'll say, okay, you are higher than 4%, so you need to come in and get a biopsy. And so that framework was created by the process in 2019. And then after those guidelines were published, that process continued as the Enduring Guidelines Consensus process, which is led by the National Cancer Institute, ASCCP, and the American Cancer Society. And it is still a consensus of 19 national organizations. We make new guidelines for new technologies like extended HPV genotyping. So when you actually know what type of HPV it is, how do you manage that differently? I mentioned the dual stain, which is another sort of way to analyze the cervical cells. And then what we'll be talking about most of today is how do you use self-collected HPV tests for screening?
Can you explain to us what self-collection tests are available now and what are hopefully coming soon?
So right now, the HPV tests that are approved for self-collection are the Roche Cobas test, the BD on Clarity test, and the Abbott Alinity test. Those are all approved for self-collection for the most part right now in clinical settings, although there is a large multi-state trial that is looking at their use in home settings as well. There's one test combination that is approved for use at home, which is the Roche Cobas test with the Teal wand, but it's only available if you become a patient of the Teal telehealth service. It's not available through your regular healthcare provider.
What does the research tell us about self-collected samples compared to clinician-collected samples?
So there's very good data that the sensitivity for detecting HPV is quite similar. HPV testing has been rolled out in Australia and Denmark and a few other places, and the results and as well as being done in lots of randomized trials, and the results overall are very promising, although there is a little bit of heterogeneity in the data, and we don't have long-term, like more than 5 years of follow-up for this. So because the sensitivity looks like it might be a couple of percentage points lower, like 92% instead of 95%. So still excellent and far better than the 70 to 80% sensitivity you get with the PAP test. Because there's a very small potential difference and we don't have good 5-year data, we're recommending that the patients come back in 3 years after a negative result on an HPV self-collection versus 5 years after a negative result on a clinician-collected HPV test or PAP and HPV co-test.
If you're looking at this from a patient perspective, what are the benefits of self-collection?
For most patients, about 80 to 90% of patients, their test results will be negative if you're talking about an average screening population, and they can avoid the speculum exam. It's very hard for people to often find a gynecologist or find a primary care provider, or even if they have a primary care provider, there may not be time or that person may not perform pelvic exams. So this is really a great option for helping catch up people who are overdue with screening, because it can be done, potentially in a nurse visit. You can, as a, primary care provider or population management specialist, could order it, could have a standing order through the laboratory or something like that. So it doesn't necessarily need to take up part of a visit with a healthcare provider, which we know that getting that can be very difficult for people. Access is a problem regardless of insurance status.
So, from a public health perspective, we're looking at this as a way to get more people screened.
Correct. Yeah.
What kind of clinical settings do you think would be a good place to expand screening outside of gynecologist's office and primary care offices that are, as you said, overwhelmed, difficult to get appointments with? Like, where would you like to see this expand to next?
So it needs to be coming from someone's primary care office or their clinician, because somebody has to be managing the results. So I don't think it would be good, for instance, if it was like coming from a CVS, from a Minute Clinic or doc in the box kind of situation, because then if someone needs follow-up, there's no system in place, and then you haven't done anybody any favors. So I think that it can be very useful if, used within healthcare systems to expand their screening to, maybe take their appointments that were only for cervical cancer screening, make those self-collection. And now all of a sudden you've opened up a lot more appointments, because you only have to have 15% of your patients coming back in for those pap tests. But I think it would be very difficult to have it function to prevent cancer outside of an established healthcare system, because I don't know how you could reliably do the follow-up that's needed for the patients who test positive.
If this is one of the goals, is to kind of expand it, it feels like self-collection's been around for a few years, and it doesn't necessarily feel like that's happened yet. Do you think providers are reluctant, and in which case, why? Or do you think it's that the system hasn't caught up?
I don't think providers are reluctant. Every provider I've talked to, certainly primary care providers, OBGYNs might be less excited because we do pap smears all the time and we have more complicated patients who probably aren't candidates for self-collection. But all the primary care doctors I've talked to are so excited about this. The complexities relate to the system. So the lab has to have the kits, offer the kits, interface with the electronic medical record. The electronic medical record has to be changed to create a new order set to order the self-collection. And then you have to establish a new workflow to call the patients to, potentially distribute the kits depending on how you're doing it. And also then to call all the patients back who have positive results and make sure they get appointments. So you have to have all that in place before you roll this out in your system. And then insurances are not all covering it. Insurances need to cover it. And then it also needs to be counted for systems that receive payment based on quality metrics for healthcare. So what percentage of your patients have had cervical cancer screening? If that metric isn't counting HPV self-collection as a screen, then you can't use it, because then your system will be punished because you've been screening with something that's not included in their metric, and so you can't use it. So all of the sort of incentives need to be aligned in terms of compensation for the systems as well, in order to roll this out without either the systems being financially punished or the patients getting bills for something that wasn't covered.
Is there a way that providers could advocate for this within their own healthcare systems?
Probably. It's probably going to, insurance is so complicated, it's probably going to vary by system.
Do you think, though, that we're going to catch up? Do you think that the system, I mean, it does seem like it can be a cost-saving measure for systems. Can it be? Am I right about that?
I think it is cost effective for the healthcare system as a whole because, for instance, Kaiser Permanente, which is a self-contained healthcare system, has been doing self-collection for 2 years. And
Hmm.
so if you have all of the incentives aligned, it is definitely cost effective. Sometimes in systems where, the insurance is not working, where the incentives of the insurance company and the incentives of the healthcare system may not be the same goals, then you have a lot more difficulty getting things covered.
Do you think we're going to catch up, though? Do you think that the
Yes.
system is going to, and when do you think we'll see a lot more of this?
It's coming. So the first thing was the large commercial labs, LabCorp and Quest, really had not been offering primary HPV screening. They'd really only been offering co-testing. But with the advent of self-collection, both of those large laboratories are starting to offer self-collection. And I think there will be enough demand that the insurance companies start to catch up. USPSTF drives a lot of insurance coverage, and if the final guidelines have language in them about self-collection, which the draft guidelines did, and I can't imagine the final guidelines would not, then that would also help with insurance coverage. I think right now we're a little bit stuck because Medicaid and Medicare coverage are governed by, in many cases, by the U.S. Preventive Services Task Force. And we're stuck back with the 2018 guidelines right now because those have been in revision for a long time, but the final are not out. So I
Hmm.
think it definitely will happen. But I think some of the slowness has been it's not like you can just order a new test and you're done. You have to update your system, you have to update your workflows, and then the reimbursement structures and quality metrics have to catch up as well.
So you mentioned the guidelines, the task force guidelines, but the American Cancer Society just came out with new guidelines. Can you explain the kind of what the new guidelines say that's a little bit different than what the old guidelines said?
Yes, so the American Cancer Society updated their guidelines for cervical cancer screening in December of 2025. And I'm just going to review all of the guidelines and I'll tell you what's new. So, the American Cancer Society recommends screening with HPV testing, and the update is that you can use self collection. And they recommend starting screening at 25. The reason to start screening at 25 is HPV vaccination is absolutely fantastic at protecting young adults from cervical cancer. So now that we have such a large proportion of the population having been vaccinated, screening below the age of 25 doesn't make a lot of sense because studies in the US have shown a huge decrease in cervical precancers and cancers in that age group. And in countries with even higher vaccination rates, like Scotland, has not diagnosed a cervical cancer case in anyone who was vaccinated on time as an adolescent. So the reason for the age shifting from 21 to 25 is because vaccination is great. And the girls who got vaccinated are now aging into screening and you're not going to find anything. So why are you torturing them? The American Cancer Society has adopted the guidelines from the Enduring Guidelines consensus process. And so they recommend HPV testing with a clinician as preferred because of the logistical things we talked about earlier, in that if it's positive, the lab can just do the sample, it can just run the sample because the cells are from the cervix versus the patient having to come back if the sample is from the vagina. And also that if the test is negative on a self-collection, you should come back in 3 years, versus if it's negative on a clinician collection, you should come back in 5 years.
Did anything change for people who are older than 29?
Yes. So on the other end of the age spectrum, we have screening exit. So a lot of people will have the number 65, the age of 65 in their minds for screening exit. But the guidelines for screening exit, which were developed in 2012, were extremely complicated. They said, okay, when someone is 65, look back at their medical record, make sure that they have at least 2 negative HPV tests or 3 Pap tests over 10 years and no abnormals and no history of precancer in 20 to 25 years and no HIV and immunosuppression, blah, blah. And so basically, it was requiring clinicians to do this very complicated, not reimbursed, and frankly, not even possible in most people don't even have that amount of data in the medical record that people can see. And so basically nobody did it. They said, oh, you're over 65, you don't need screening anymore. And What happens is about 25% of our cervical cancers occur in women over the age of 65, and the mortality is double because it's diagnosed late. This is bad because it's still preventable. And we also are doing fewer hysterectomies, so we have more women aging with their uterus in place, which is going to make more cervical cancers because if you have a cervix, it can get cancer. If you don't have a cervix, you can't get cancer. So all of these great minimally invasive treatments we have that help so many women avoid hysterectomy do leave them with an organ in their body that can get cancer later on. So we have to exit people better. And so the American Cancer Society's new guidelines make this simpler. They say, do an HPV test or co-test at 60, do an HPV test or co-test at 65, and then if that's negative, your patient can probably exit, with some caveats that if someone has an organ transplant or HIV or a history of cancer, precancer, they shouldn't, but pretty much everybody else can. It doesn't really change what was supposed to happen, but it makes it proactive, saying like, if you see someone who is 60, please screen them. If you see someone who's 65, please screen them, instead of saying, around this age, go find someone's extensive medical record and see what you think, because nobody was doing it. And what we actually found when we looked at women between the ages of 64 and 66 was that 2/3 of them did not have enough screening to meet exit criteria. So basically, they were underscreened. And then when we looked at the medical record, the vast majority of women didn't have enough information in the medical record that even if you tried to do your due diligence and look for it, you wouldn't be able to find what you needed. So because those guidelines were just not able to be implemented, we kept the spirit, but changed the letter and made it proactive. Screen at 60, screen at 65.
Okay, so we have some changes to the younger generation, some changes to the older generation. For those of us in the middle, are there any changes?
The only change that's throughout all ages is self-collection is an option. And the screening at 25, the starting screening at 25 is not new in this update. That was in the 2020 guidelines, but I will say it hasn't been adopted very much. So,
Are
worth reiterating.
And is that, do you think, because the task force hasn't weighed in yet, so insurance hasn't changed, or is that because it just takes a while for kind of the guidelines to trickle down to all providers on the ground?
So I think it's partly because the task force hasn't weighed in, partly because the American Cancer Society guidelines are not as widely known about as other guidelines. But what we also see is happening, which is another reason to use HPV testing in this age group, is the 21 to 29-year-olds are not screening. Like they're voting with their feet, and their screening rates are declining year over year. And so I think it is important when you get a 21 to 29-year-old in your office to make sure that they do get screened with the most effective test, which is an HPV test and not a pap test. Also, I think it doesn't make sense to require a speculum exam for screening for people ages 21 to 29, but then allow them to start self-collection at 30, because I think that's going to make the 21 to 29-year-olds even less likely to screen if they aren't able to do a self-collection until they're 30. So I hope that the HPV test collection at the age of 25 will be part of the USPSTF revised guideline when it comes out, and I'm glad to see it as part of the American Cancer Society guideline.
Just to clarify, to make sure that I understand, between 21 and 25, you wouldn't use self-collection, you wouldn't use HPV, you'd just do a pap if they were in your office, or what?
So right now, if you have someone between the ages of 21 and 24, if you're following American Cancer Society guidelines, you don't screen them for cancer. If you're following USPSTF guidelines, you would screen them using a pap test.
Okay.
Between the ages of 25 and 29, if you have someone in your office and you are using the current USPSTF guidelines, you would say that they need to have a pap test, and an HPV test is not an option for them. But if you're using American Cancer Society guidelines, then you would recommend screening them with an HPV test. And you can use self-collection. And the younger women tend to be very comfortable with self-collection for STD screening and all of the other things. So,
and we grew up sticking Q-tips up our noses for COVID. I think everyone's getting a little more comfortable with the general concept of testing ourselves for things.
yeah. And so I think that having the self-collection option for people ages 25 and over will be very important to maintain screening coverage in that age group.
Do we have an idea why 21 to 29-year-olds aren't getting screened? Has there been any research done to kind of, figure out what it is that's preventing them?
I don't have the answer to that question. I can,
Feels like a very health conscious generation in a way.
yeah, I don't know if it has to do with access. I don't know if it has to do with habits. Like people who are, over 30 are much more of the generation where you had to come in every year for your annual PAP and you had to get your PAP to get your birth control pills and all of those things, which are no longer a thing. And so I think it's just because it's recommended less often, because it's harder to find a provider, and because it's no longer tied to other health services that people in that age group really want, like birth control and STI screening, which can now be done by urine and all of those things. I think it just falls through the cracks a lot more.
Just a couple more questions. Just one personal question. You said you loved working in HPV because there's so much stuff going on. What are you really excited about right now?
So there's just a lot of new knowledge about how to use HPV testing. And then there's a lot of work and development with better ways to manage the positive results, because our goal is always to find people who have precancer so we can treat them and then people don't get cancer. And I mean, cervical cancer is the most preventable cancer because we know that if someone has a precancer and you don't treat them, about half of them will develop a terrible cancer over the next like 10 years. And if you treat them, the risk is less than 1%. And the treatment is something we do in the office in like 10 minutes. So it's just such an exciting place to be, because with vaccination and screening and treatment, the World Health Organization has talked about eliminating cervical cancer because it's such a preventable cancer. And vaccination is, more than 95% effective in preventing cancer. So, we can have a cancer-free generation just from vaccination, but there's also all this exciting work happening in the screening and management field to try to make it easier and more efficient and more effective for adults who were too old to get the vaccine when they were still kids.
Thank you so much for listening. If you'd like to learn more about cervical cancer prevention or self-collection, visit ashasexualhealth.org or the National Cervical Cancer Coalition at nccc-online.org. You can listen to all episodes of the Sex Plus Health podcast on Apple Podcasts, Spotify, or wherever you listen to podcasts.